Well, first of all, I'd like to thank Jackie and the organizing committee for inviting myself to speak today on this project. So I'm going to speak about our research study entitled Harm Reduction Within Mainstream Services. What are the challenges and opportunities to reducing the harms for people who use drugs? So I'm Dolores Levangie, and I'm the research coordinator for the project. The key goal of this research study is to explore the policies and practices within emergency departments and shelters that guide the provision of services to people who use drugs, including the provision of harm reduction services. We define drug use as the use of any drug, either legal or illegal, in ways other than as medically directed. The funding for the research has been provided by the Canadian Institutes of Health Research, or what is more widely known as CIHR, and I would like to thank them for the funding, without which the research would not have been possible. So this is a community-based, collaborative research study. This means that university-based researchers worked closely with individuals outside of academia to develop both the research question and the research design. More specifically, the research has been carried out across Atlantic Canada, with individuals working in community-based social service and health-related organizations, such as AIDS organizations, needle exchange programs, housing initiatives, and a community health center, a few of which we have in the room with us today. It also involved physicians working with people who use drugs and policymakers in the areas of addiction services. So a key reason for taking this collaborative approach is that we believe it'll help to ensure that the research results can be used to create meaningful program and or policy change and improve the lives of people who use drugs. Extensive research collaboration with those who have first-hand knowledge of key issues in the area of addictions is important to develop timely and relevant research. And moreover, collaborative relationships with the program and policymakers help to ensure that people who need the evidence from the research to change the policy and programs have ready access to the research. So as I mentioned, there's a few people here in the room today that are part of the team. We have Mark Deitman, as well as our project project investigator, Lois Jackson, also Diane Bailey, Cindy McIsaac, Julie Dingwell, Debbie Warren, Jackie Gahagan. And so why, you might ask, are we conducting this research within emergency departments and shelters? The reason for this is that many people who use drugs, particularly those who are more socially and economically marginalized, frequently use these services. However, even though we know that people who use drugs often use emergency departments and shelters, we know relatively little about the practices and policies within these settings that guide the provision of services to people who use drugs. And perhaps more importantly, we know very little about the challenges which people who work in emergency departments and shelters face in providing services to this population. It is this gap in knowledge that the research is attempting to fill. We know that key services are crucial for both the prevention of HIV and hepatitis C, as well as improved health. It is therefore important to understand the challenges faced by those providing health and social services. In order to begin to understand the practices and policies within emergency departments and shelters, we spoke to people who work in these settings. Our research proposal was reviewed by the appropriate ethics review boards in all 4 provinces, and in total we interviewed 57 people who work in emergency departments and shelters across Atlantic Canada. We interviewed people after obtaining their informed consent, and of course we only spoke to some people who work in these settings, and only to those who volunteered to talk. Consequently, we clearly do not have knowledge of all of the practices and policies within emergency departments and shelters across Atlantic Canada regarding people who use drugs, or more specifically, all of the challenges that people who work in these settings might face. So this is a clear limitation of our research. However, our intention was not to gain a totally comprehensive picture of all of the practices and policies. Rather, we wanted to begin to explore the issue and to understand from the perspectives of people who work in these settings some of the issues that might affect the provision of quality health care and social services to people who use drugs. So where are we right now with this study? At present, we're analyzing the data, and we are starting to talk with various stakeholders about some of the preliminary findings. In fact, quite recently, we had a number of workshops across Atlantic Canada to talk about these findings. One of the key findings that I'd like to talk about is that there is a need for an integrated, adequately resourced approach to the provision of health care and social services for people who use drugs. One that clearly recognizes the multiple complex needs of the population. Let me explain by providing an example. So a number of people we spoke with in emergency departments indicated that the departments are organized around acute health care issues, more specifically physical acute health care issues such as broken bones, heart attacks. However, many people who use drugs go to emergency departments for a variety of other health issues, including chronic addiction health issues, or chronic mental health challenges. As a result, they may be referred to other services, or a consult might be required. This takes time and can be frustrating for all parties concerned, not just for people who use drugs, but for people who work in emergency departments and are trying to make referrals. The person who uses drugs may have to spend an extensive period of time in the hospital waiting. Not only is there not often a long wait time within the hospital services, but also for community services. So that is, some of the services that are needed are not provided within the hospital setting, but within the community. Often referrals to the community services, such as detoxification programs or methadone programs, have extended wait periods. So it's not just that people would have to wait for hours, but wait for months in order to access these services. This challenge of limited community resources was raised not only by people working in emergency departments, but also those who work in shelters. Some people working in shelters spoke of limited spaces within the shelter system for the homeless, including people who use drugs, and often scarce staff resources for addressing individuals' multiple complex needs. So what the preliminary findings indicate is that we have a healthcare and social services system where A, things are provided in silos, and people who have complex health and social needs have to go from one place to another place to another place in order to access all of the services they would need. And B, often the services they need to maintain or improve their health are not readily available or they're in limited supply. This suggests to us that there is a need for change in how we provide services to people who use drugs. There are various possible models or ways we might organize healthcare and social service provision, and of course, depending upon the resources and other issues, these models may need to vary from one community to the next. However, one possible means of improving service provision is to have greater integration of services from across health and/or social service sectors, and more timely access to critical harm reduction services, such as methadone or detox programs, as well as housing. This, we believe, is critical to both the prevention of HIV and hepatitis C, as well as the improvement, more generally, of people who use drugs. Thank you.